Welcome to the Physician Associate Podcast.
Hello, welcome to this episode of the Physician Associate Podcast. My name is James. Today, I'm delighted to be joined by a huge team of physician associates and consultants from the Norfolk and Norwich Hospital to discuss a really innovative use of the PA role and how they're expanding and improving the service that they can offer to their patients. I'm joined by three consultants. I'll let them introduce themselves.
I'm Tom Graham, one of the consultant gynaecologists in the Norfolk and Norwich.
I'm Fran Harlow. I'm consultant obstetrician and clinical skills lead for the Physician's Associate Programme at the Norfolk and Norwich.
Hi, and my name is Richard.Haines. I'm a consultant obstetrician here at Norfolk and Norwich and postnatal services lead.
I guess my first question is, what made you consider employing physician associates into your departments?
I've been involved with the Physician's Associate Programme since its inception at the UEA, and I've been impressed from the beginning at the standard and level of the students that we had, and I particularly was impressed by their mature approach to looking after patients and taking on responsibility, really, in the clinical environment. Early on, I started hearing about physician associates in other hospitals and what their roles were, and I rapidly saw that physician associates who had niche roles really provided an enormous service to hospitals and provided a service that was really rather different from junior doctors, which I think is the key, in my mind, to physician associate roles, because they're not the same as junior doctors. They don't rotate around every 3 months, every 6 months. In general, if you get a good physician associate and make them a good job, then they'll stay where they are and provide an extremely high level of service. And in doing so, we got two posts associated with the obstetric department of the two physicians associates that are on this podcast today. And by virtue of Health East England realising that you needed to provide some education for these physicians associates as well, we managed to get a grant to provide education for both of them. And hence we I appointed the two educational supervisors as the other consultants on this podcast.
Yes, it's echo Fran. So I'm Tom Graham, I'm one of the consultant gynecologists. So for me, it's seeing physician associate trainees, seeing how they develop in their training, and also having first-hand experience of physician associate working alongside me, knowing that actually they provide huge value. I think one of the things that's really important about physician associates is the way that they think. So physician associates think like doctors. They don't think like nurses. They're not constrained by the protocol kind of driven culture that exists in nursing. It doesn't affect physician associates in the same way. So they are far more malleable, they are far more trainable, and they can do extremely diverse roles within the NHS. They can do almost anything. They're extremely valuable assets to have.
Yeah, absolutely. Thanks, Tom. Thanks, Fran. Just from my perspective, actually, I mean, I've been a consultant now for nearly approaching 3 years, and actually, previous to that, I probably honestly would say I've had very little experience working with the PAs. I had some experience when I was a senior trainee and here at Norfolk and Norwich, and then in my first year as a consultant, but mainly on the basis of teaching sessions and interactions on the ward and things like that. But I would completely echo what Tom is saying. There's a huge niche and a huge potential here, and it is how these guys, is how their mindset works. And I have to say, it's just an absolute pleasure to have somebody who, these chaps are so diligent, they're proactive, they're interested, they're keen. So actually, in order for us to produce a PDP, which I think is probably a sensible thing to do, it really helps to sort of envelop the personal, professional development elements for these chaps, and it really is an absolute pleasure. I would probably say a small challenge might have been that there's no hugely strict curriculum, but actually for us, I think we've probably turned that on the head a little bit and used that to our advantage, because the kind of tasks that these chaps are doing here at Norfolk and Norwich is so specific, and I don't think there's many obs and gynae PAs in the country, and I certainly think there's not many obstetric-based PAs in the country. So we really have utilised that in terms of the projects available to them. So they haven't been here that long, but they have provided a massive benefit to the service and us as consultants at the moment. And because they are permanent members of staff, they are not treated as junior doctors, so the potential is entirely different. So that really has been a pleasure for me.
I think at last count on the census in 2019, I think just over 1% of all physician associates were working in obs and gynae. So, were there particular pressures in your departments that were going on at the time that made you wonder about recruiting PAs?
It's a really good question. We'd have to speak slightly separately, that's really, because obviously I deal with gynaecology side of things and you're dealing with obstetrics side of things, and there are different pressures within that.
So I suppose from an obstetric perspective, our biggest pressures have been the discharge process, actually, of our ladies from the postnatal ward, because that has always historically been a tricky conundrum to crack. And actually, it was my main brief when I was employed, actually, to improve the discharge process, streamline it, innovate it, and therefore reduce the length of stay, only because our frequent yearly maternity surveys show that women need to be at home quicker. So actually, what I have probably realised is that actually this can't be done just with the medical team and the midwives. We need to have other members of that MDT over there on postnatal. And actually, out of anywhere in obs and gynae, the postnatal ward is probably the most flux ward in terms of MDT collaboration. So that's probably where I wanted to target, really. And we're starting to focus on some discharge pathways and discharge processes, actually, in terms of helping him to discharge women from the ward, because universally this used to be a medically orientated task. Usually the doctors would have to see most ladies for discharge. We've been working on a discharge package for a physician associate facilitated discharge, which is where they have the autonomy to be able to discharge high-risk patients from the postnatal ward, and therefore relieving the pressure on the doctors and the midwives and helping the doctors to go elsewhere, wherever the clinical activity needs. So from my point of view, that's been a big project that we're working on. We're taking it to our maternity guidelines next week, and that's something that will be hopefully ratified and will be pushed out within the next couple of months. So that's quite exciting, actually. It's quite an exciting time here. Chris also works in the neonatology area of things as well. So he has lots of responsibilities with NICU and baby checks and things like that. So he has a very flexible working week. And that's actually something else that's great about the PAs. We've been able to sit down and have a talk about how he wishes his week to look and how that works for me, how that works for Chris, how it works for the department. So he has a very flexible time, enabling him to prioritize his tasks throughout the week.
Okay, so from the gynaecology side of things, there are similar kind of things. So obviously junior doctors are on a cycle, on a rota where they work weekends and they work night shifts. And because of the European Working Time Directive, we have lots of compensatory days off in between to ensure they're not working too much, which is obviously good for them, but it means that there are often lots of gaps in the day in terms of continuity with who is around. So, for example, a junior doctor on a standard sort of 1 in 8 on-call rota may only be around on the ward to an average of 3 out of 5 days a week or something like that. And what Chris does is he provides us with a great deal of continuity in terms of also having somebody on the ward who's familiar with working on the ward, and familiar with what's happening on the ward, and is able to support those processes. So one of the big problems we have in gynaecology at the moment, and in fact it's a very long-standing problem, it's gone way back for years before I even came to work here, is that electronic discharge letters for patients are not routinely completed in a very organised or ordered way. It's a bit unfathomable, really, because it's a basic thing that you should do when somebody's being discharged. You should complete an electronic discharge letter. It takes all of about 2 minutes, and it's important for the GP, and it's an essential part of clinical governance, as well as communication with the patient's general practitioner and indeed the patient themselves. So the fact they're not being completed is very disturbing. It's not a big number, but it's a significant number. And Chris is working to correct that. So he's completing those that haven't been completed. But we're actually about to start doing a service evaluation, collecting data on this. So he's going to be collecting data on the time, location, the grade of the person that's done the decision, and looking for themes and trends. So we think we know where the issues are, but we need to prove it beyond doubt. And obviously, once we've done that, we're going to do a project to improve that, and Chris will be leading on that. And that's a great example of the way that Chris is not only doing clinical work on the ward in terms of reviewing patients, which he's learning to do, supporting ward work and also usual ward jobs, but he's also doing a quality improvement project that's likely to have far-reaching consequences in terms of how we change the way that we do EDLs within our department, because this is something that clearly needs to change because the system in place clearly is not working properly. So that's just a great example of a huge value that Chris brings to our gynae team. If you're listeners, we should perhaps clarify that we've got 2 Chris's and we're talking about...
Should we bring Chris and Chris in?
So I'm Chris Kelly. and I graduated last year from UEA. So I've been in this post for coming up to 7 weeks. So I'm still relatively new here. So a lot of what I've been doing is kind of getting to grips with it in the last month or so, and then learning the key skills as well to be effective in gynaecology. But already what I've seen is that I can be useful in this department. We have lots of junior doctors who are rotating around, and their weeks are split between theatres, on-call obstetrics, on-call gynaecology. So they might do one gynae on-call a week as an F2 or as a GP trainee, and often the processes and things are difficult. How do we get that scan for that lady in early pregnancy? How do we do these things? And those are things that I'm now becoming more confident in and able to advise and help. So hopefully help speed up that flow and pathway, because things kind of break down when the simple things can't get done quickly. But yeah, that's my main role. And at the moment, I've started clerking the kind of emergency patients as well, who come in as ambulatory patients onto Cly ward, often referred from A&E or GP. I'm developing my skills there with gynecological examination and diagnosis and investigation, and hopefully my role will increase and my experience will increase.
Thanks, Chris. And for any physician associates out there who are listening to this and considering a role in gynaecology, are there any top tips or bits of advice that you would share as you make those first few steps into the first few weeks of your career? What have you found most useful to keep in mind?
I think it's that as a student, our training is a whistle-stop tour. So you're going to have lots to learn and lots to read up, and those kind of key skills that you'll be doing day in, day out, you may not have ever done, like a speculum examination on a real person. So it's about kind of making sure that you know your limitations and really kind of seeking that help when you begin to really develop those skills properly, and not just kind of jumping in and assuming that you've been taught it once and did it on a mannequin. So I think it's one of those departments where we had limited exposure, particularly as a male student as well. I think my opportunities were probably less than some of my colleagues to actually get hands-on and apply those skills.
And I think that's very true for a lot of medical students as well, actually, if we're being very honest. Many medical students won't have actually done an actual speculum and pelvic examination on an actual patient until they come to work as a junior doctor in the department. So actually, in many ways, you have as much gynaecology experience and knowledge as many of our junior doctors rotating into the department as part of their general practice training or the foundation training, or when they start the training of some gynae will have. That's
where in the future I will become more useful when I'm more experienced, is actually being that constant presence that can help guide the trainees coming through with those skills.
I think that's a really valid point, actually, Chris, that you've made, because that's something that I don't think I picked up on, actually, that you are permanent members. I think I did say, actually, but actually, you're permanent members of the staff, you're a permanent face there, so you have that ability to be able to lead that area when you're seeing the rotational capacity of all the doctors coming through,
That's really interesting. Thanks for your thoughts on that, guys. When I'm having conversations about physician associates to other people, one of the, concerns or arguments against employing physician associates at the moment that comes up frequently is the inability to prescribe and difficulties arranging tests with ionizing radiation. Chris, as a PA in gynaecology, is that much of an issue for you? How are you finding that?
I don't currently see it as a massive issue for me, because I'm able to kind of clerk in patients, see patients, make decisions. And as long as there's the kind of support and the chain of command there, that means that if prescribing is required and someone is available to do that, then that can happen. There are frustrations with it as well, particularly about ordering kind of scans and things and ionizing radiation. Prescribing, I think, is probably inevitably going to come for us. I have worries about prescribing coming for us as well, in terms of pushing us towards being junior doctors rather than that separate role as a physician associate. It would have to be done carefully, because as soon as we can prescribe, do we then get put on the on-call rotas, and act as auxiliary junior doctors, and then our kind of uniqueness in that we can provide that continuity in one place and have other areas of our work in terms of like service improvement and things, would that go because we have those skills? But alternatively, there are definitely times where I'm like, well, I wish I could prescribe that bag of fluid for the hyperemesis lady who's just come in, and I need to go find someone to do that, I think.
I agree with what a lot of what you've said. I think the roles of physician and physician associate complement each other, don't they, in terms of how we work. And you're right about the fear of altering the role of the physician associate such that you can just be absorbed into a junior doctor rota to sort of fill gaps and things like that. I think that's something that I would not be keen on. The value is within those sort of regular hours, regular continuity roles. But I think that doesn't necessarily mean that you can't have prescribing rights and rights to request analysing information the same way the junior doctors do. But I think having the ability to get prescribing rights for physician associates is an important step on the road to developing that role. And actually within medicine, there are lots of examples of doctors who work in non-training grade roles. So we used to call these SAS doctors or trust grade or staff grade doctors. Those kind of distinct roles that I think we need that are key to developing with the physician associates and add real value for us. We should push back against you being absorbed onto the rota. I mean, some people might want that and might want to work in that way, but I think actually once you've done that, you've just directly replaced an SHO or junior registrar with a physician associate, which I think is not necessarily the healthy role that you want. You want to have some degree of autonomy, don't you, in some niche that you work in. I think a physician associate could work at almost any grade, within medical training, right up to senior registrar level, if they're appropriately trained, experienced, and supervised. So it's about length of your training experience. It's highly individualised. What I think what we have to remember is that physician associates are individuals, and I think what obviously is important is maintaining good clinical governance, good processes of supervision and accountability, and that's where registration for you guys, I think, is so important, and having an appraisal process. And I know we had some email exchanges over the last day or so, and Richard asked some really pertinent questions about how we should appraise Chris in terms of having a regular appraisal system, because obviously for junior doctors we have an annual sort of appraisal process. They go through a cycle, which actually is a massive distraction in some ways, because you have to spend all your time collecting this evidence and collating this evidence with this external panel to review you. In some respects it does sometimes take away from training. So having a slightly lighter approach to that, like the medical appraisal that we go through as consultants, which is a much lighter process than what junior doctors go through, probably more appropriate. But that's maybe another issue. I think the other thing that's interesting to discuss and consider, and I don't know what you guys think, but it's interesting to know what you think about this, is the idea of preceptorship for physician associates. So obviously you finish your physician associate training, and then you then apply to be a physician associate working with, whether it's an A&E, whether it's in general practice, or a role like this one. Whereas obviously for junior doctors, they'll have to go and do a foundation year. In fact, 2 years, won't they have to go and do Foundation 1 and Foundation 2 before they can then go and do sort of further training. And whether we need to have some kind of preceptorship program for physician associates, and if so, how that was organised and coordinated nationally.
But I guess, as Mr. Gray was saying, every physician associate is an individual, and some people may want that. But I know that, well, you and I have discussed at length about kind of actually having that niche and that unique role, but actually, would we need a preceptorship to be able to go and do that effectively?
I think your national exams are very robust in a way that junior doctors don't do national exams. They do the exams at the university, and there's some variation in quality in terms of what happens. And the foundation program levels that off quite well. But physician associates is quite different. And I think the standards that you have to attain for that national exam are high. And obviously you're all graduates, you're all mature students. You're often a little bit older, perhaps, than junior doctors when they come out the other side of their training, and that helps you too. And key to that is having some kind of formal supervision in terms of having a named supervisor, somebody who's looking out for you, who's got some responsibility for you in terms of supporting and developing you. I think that's crucial for all physician associates throughout the whole health service in terms of how they work, that they have that accountable person that they work with who helps them to develop and helps them to grow and works with them.
And talking about physician associates being innovative and carving out their own unique niche, if I bring Chris Barker in to explain a little bit about how you work across both obstetrics and neonatology.
I'm Chris Barker. I'm the physician associate working in obstetrics and paediatrics officially. So my job is split 50-50 between obstetrics, primarily the postnatal ward, and the TC postnatal side of the NICU. So I don't spend much time over on the unit in the sort of more intensive side of things, though I am planning to get some experience over there just to inform my work on the postnatal ward. And the role, as I understand it, and Miss Harlow will be able to give a bit more information, I'm sure, but came about from the two departments working very closely, particularly with our transitional care being on the postnatal ward, being very heavily interlinked with the postnatal side of things, there was a bit of frustration with there not being any sort of clear bridge between the two. And thus came about the idea of getting a physician associate with our ability to be flexible, our ability to fill these niches, came about the idea of this role. And every morning I do the ward round on Blakeney for the obstetric team, as Mr. Haines talked about, that I'm able to discharge, and then splitting my week with that flexibility to assist in the baby check clinics, the discharges from the transitional care unit, and working up to being able to assess babies on the unit as and when needed, just as I do with the postnatal ladies, so the ad hoc medical reviews.
Sorry, just to add into that, the reason this post arose primarily was twofold, really. One, we recognised that there was a problem with patient flow through the department and discharging mothers and their babies, and that was because two different people were discharging the mothers and the babies, the mothers being discharged by the midwives or obstetricians, and the babies being discharged by the paediatricians. So that's where the unusual and unique role of Chris's job came in. But the other reason we went down this route was because one of our fundamental problems at the Norfolk and Norwich is in terms of funding, and this gave us a unique opportunity to have a job that was funded by two different departments. So each department only had to generate half the amount of money for a physician's associate. So it was a win-win situation all the way around.
Brilliant, thank you. And so, Chris, you're able to work with the new mother and work with their new child as well.
So yeah, absolutely. And I found that that's actually been a real benefit. Often I will go in to see a new mum for a medical reason, and I'll be talking to her, and she'll have questions about her baby. She'll have questions about even just simple questions that the obstetric doctors typically would shy away from because it's not their wheelhouse. Quite understandably, they'd be like, "This is something that need to talk with the midwife or the paediatrician about." Having that bridge made it very, very good for me I'm very able to discuss these things with mums, and as long as it's something that I'm comfortable with, and as my skill set grows, then that will give me a lot more flexibility to discuss these things with mums. And I think as well, I found seeing mums on the ward round in the morning and then coming back later to do the baby check on a clinic day has really, I think, helps them a lot, because it just decreases the number of strange new faces they're seeing at a time that is quite difficult, quite stressful. And I think it's helpful for the doctors and for the midwives and for the TC nurses to have somebody they know they can ask and come to me and sort of say, what's going on with this mum, what's going on with this baby, and I have that. Having that bridge makes it much easier rather than them trying to have to hunt down the right person. I'm consistently there. I'm consistently able to act as a bridge for everybody. I think that seems to have smoothed things quite nicely on the ward.
And that must be helping from a discharge point of view, thinking in the hospital-wide system, having one person being able to potentially discharge both mother and baby at the same time, rather than needing to link up the obstetricians and the paediatricians review.
Yeah, absolutely. I think that's one of the areas that it's really come to light, is my ability to discharge mums, discharge babies. If we're discharging a TC baby, for example, I have a much easier time getting to grips with exactly what's happened with the baby, but going through the notes, seeing what's going on, and distilling the relevant information into our discharge letter.
Brilliant. And I guess the final bit for me then would be, what are the plans for the future of physician associates within your departments? Where do you see things going next?
Oh, goodness. That's a big question, isn't it?
So I think our next role really is to try and make sure we keep hold of these guys. But I think as people are increasingly seeing the role of physician associates in our department, I suspect we're going to have a lot more enthusiasm later down the line for having further physician associates in obstetrics and gynaecology.
I think from my role, I know Mr. Haines has a wealth of thoughts, and every time I speak to him, he says, "I've been thinking," which is always helpful. And we've got lots of projects in the pipeline to give me a more varied working week, to give me autonomy over a range of areas, not just in the obstetrics, but also within the neonatology. So I'm in discussions with the consultant about taking over the Yellow Alert Clinic for prolonged jaundice babies. Mr. Haines and I are looking at developing a wound care package and a wound care service. So there's lots of projects and audits and development that comes from that I think will keep me very busy for the foreseeable future.
I think that for Chris Kelly in gynaecology, we've got ideas and plans for how he would be useful. Obviously, he's now started clerking patients and reviewing patients, which takes enormous pressure off our junior doctors and junior registrars and adds real value to the processes on the ward. Once Chris is established in doing this, there are some other roles that we think would be very helpful for him. So one of the things that physician associates are very valuable for doing is assisting in the operating theatre as a first assistant in surgical theatre lists. And that is an area where we often need support and help, particularly where we need a third assistant for a day of operating. And training Chris as an expert assistant in the operating theatre is something that I'm keen to do. He's already been to the operating theatre a number of times, and that's something we're keen to develop further. And that may lead into further specialist roles in the operating theatre. So, for example, in urology here, there's a physician associate who works as the robot practitioner for the robotic operating theatre lists, doing particular tasks that are very repetitive, but important that they're done very carefully and very well. And a physician associate doing those roles rather than a junior registrar who's allocated that theatre on an ad-hoc basis is much better. So looking at those kind of roles within Chris, for Chris as we develop our services here, is sort of the direction of travel, really.
Fantastic. And for anybody who's been listening to this podcast, if you've got thoughts or questions that you'd like to put to the consultants and the physicians associates that we've featured on this episode, I'll leave all of their contact details in the show notes below, so you'll be able to find them on your podcast app there. Thanks everybody for joining me. Really appreciate you all giving up your time to talk about these really amazing and really quite novel roles for physicians associates. And thanks to you for listening as well. I hope you found that really useful to find out a bit more about how physicians associates are working in new and innovative roles. If you'd like to, you can get in touch with any of the consultants and the PAs that we've featured on this episode. And the PA podcast, we're also on social media as well, just at PA Podcast UK. Thanks for listening, and I'll see you again in the next episode. Perfect.
Thanks for listening to the Physician Associate Podcast.